Reducing infections in surgical practice. I'm going to try and go fast to fit it in because I was late, didn't get my coffee yet. So anyway, when we look at infections, we want to know how bacteria get in and also look at the host. So it really involves all these things. The patient, the surgeon, the procedure, all you guys, the skin prep, what kind of antibiotics we give, local antibiotics, and the post-op care. And we're going to look at each one of those. The host. So what we don't realize, the host is probably one of the most important parts of the equation. Very interestingly, what percentage of wounds, let's take, for example, a little discectomy or a little microsurgical wound about, just about that big. What percentage of those wounds do you think are contaminated in a hospital environment in the first 30 minutes? 10%, 5%, 1%? 70%. So we're not really sterile. We'd like to think we are, and so the majority of infections occur, 95% of them are contamination at the time of the surgery. Not that they had somebody with MRSA in the next room on the surgical floor, somebody had, an infected total joint across the hall, the nurse didn't wash her hands. All that stuff is important, but the 90 to 95% of infections occur with contamination at the time of surgery. Well, how come most people don't get an infection? Because they're actually a very resilient host with a really good immune system that's pretty healthy. But well, look what's happened is we've evolved into the guy at the end with a big sippy cup and a Slurpee, and there's probably a little vodka in there too with the soda, right? So, and the diaper. No, those are just European swim trunks. I have a pair of those, and you're not going to see them. Thank you. So as Americans especially eat terribly, junk food and all that, and we get heavy. We also get diabetes. So just our physical presentation, it's actually studies look at the depth of fat that you have in the surgical wound is directly related to the infection risk because that fat tissue doesn't have a lot of blood supply and it doesn't heal up and close very well. It makes a lot of tissue juices and it's like a perfect culture medium for any bacteria that get in. So if you take a large wound, almost 100% of those are getting contaminated. Guess what? We have a big problem. The other one is diabetes. We checked the hemoglobin A1C. These are all things you guys can't control. Big, heavy patient that smokes has diabetes. A lot of the stuff that we eat is like French fries and pizza and quick foods that don't have a lot of protein in them. So a lot of Americans are actually malnourished. They're large, but they're malnourished. When your protein stores are down, your immune system gets suppressed. Other things we don't think about is people with rheumatoid arthritis, or even gout. People on colchicine with just simple gout, they don't think about it. Surgeons don't recognize it. The medical doctors don't recognize it. That almost stops your local wound immune response at preventing infection. Then also we look at MRSA colonizations. We always say, wow, maybe that patient's got MRSA, let's put on the little blue or green or yellow plastic thing, and we're going to look like aliens or the Andromeda strain. Does anyone remember that movie, Andromeda strain? Or like the Ebola, so we're treating MRSA like Ebola. So what percentage of people in the just regular civilians, non-hospital employees are colonized with MRSA, you think? 10, 20? How much?
80.
Yeah, it's about 30%. When we do screenings in the pre-op holding and or before surgery, pre-anesthesia testing, only about 10% of people show up as being positive. So we're not missing the other 2/3. So we have, if we admit 100 patients, we're detecting 10. There's another 20 that are coming in that have MRSA. We're just spreading it around. We don't even know, right? And then how many people, what do you think the rate is of hospital because we all say working in a hospital, living in a hospital, having been in a hospital increases your risk for MRSA. So guess what you guys have? MRSA. Yeah. So nobody knows what the incidence is in the hospital employees. You know why? Nobody wants to test it because we wouldn't be able to run the hospitals. So this is almost ludicrous thinking that we take all these crazy precautions. And I hope the administration doesn't get upset with me. This is crazy, the requirements that we do, and we go, oh my gosh, we're going to find out half the patients that have it, but probably most of the staff has MRSA, okay? So, but most of our patients don't get infections with it, right? That's because we have a good host. Hygiene, contamination, and wound healing. If you think about it, if we take off and put a patient on the table and we square it off and we scrub and put chlorhexidine and betadine and alcohol, how's the MRSA in their nose going to get in the wound unless the anesthesiologist is picking their nose and going like that and sticking their finger in the wound? That just doesn't happen, does it? So most of the contamination actually occurs via the surgeon and or the staff. Okay? So let's take a look at the surgeon. You all know that the new surgeons coming out of training are super duper fast. Not. And so those guys are very well trained, but the new training programs, they just don't get the surgical experience. Like when I was trained, they didn't care about patients. They let me operate on them. Right? But I got a lot of experience, so when I came out of training, my surgical skills were probably had more opportunity for training than the people that are coming out now with all the new rules, regulations, and all that. So new surgeons come out, just don't have the same experience. There's surgical technique, how you handle the tissues, what kind of forceps you use, how much you use the bovie, how much you strip tissues. This all creates dead space and dead tissue. The hygiene of the surgeon. What if the surgeon has eczema or psoriasis, or doesn't wash his hair and has dirty, greasy hair? Or the other thing is shaving right before you go into the operating room. I come in with a stubble every time I operate. I don't shave on purpose to reduce skin flakes and stubble that might get in the wound. I also, believe it, this sounds crazy, you're going to learn more about me. Not only do you know about my swimsuit, but I take a shower with Head and Shoulders. I wash my whole body with it to reduce skin flake and contamination. Double gloving. What percentage of gloves have holes in them? 1 to 3%. All right, so if you take another glove and pull it on, you'd think you'd only have 3% of 3%, but it's way less than that because the chance of getting 2 holes in the same place is about 1 in a jillion, right? So double gloving is really, really, really important. If you're not doing it, shame on you. The other thing we like to do is change gloves after we drape because it's very easy to contaminate yourself. Hand prep. We go in there and we scrub, right? And right after we scrub, we got all the foam all over our hands, what do? Rinse our hands off. Is that water sterile? No, it's not. It's been cultured. It's full of Pseudomonas. Wow. So we're walking in there, oh, I'm sterile. No, you're not. So what about the surgeons? We never test a surgeon for MRSA colonization. And does decolonization really work? We don't know. There's some studies that say it might work, where you stuff the muciporin up the nose, make them take rifampin and all sorts of antibiotics, and they get sick, and they clear for a while, but if you retest them, it still shows up. So what about the procedure? This is an example of somebody with a really big knee and a knee replacement, right? And so let me show you something. See, where's the eye band here? The eye band is peeled away from the skin edge. So I'm going to show you another slide that the reason the eye band works is there's a lot of bacteria in your pores that are trying to get up and get out. And the eye band seals that, so you cut, only if the eye band sticks, you cut through the eye band and skin, you don't have any skin exposure to contaminate the implants in the wound. After about 30 minutes or so, the bacteria are already coming out on top of the skin. So that's why we like the chlorhexidine. But anyway, the size of the incision, the duration of the procedure, that makes sense. The longer it's open, the more likely it is they get contaminated. How much tissue we disrupt? Are we putting implants in there? The microscope increases our contamination a huge fold. There's studies that look at you can almost double wound contamination just by bringing in a microscope. It's, how many people have draped a microscope? Pretty hard to do sterilely, isn't it? So, stab scrubbing in and out for breaks and setups. So every time you scrub in, I want you guys to think about it. That white cuff on your gown is considered contaminated. Do you know how many times I see people putting on their gloves, grabbing the gloves with the white part of the cuff? You've just technically contaminated yourself, but we just go on with the procedure. And it's very difficult to self-glove without contaminated. All right, so every time somebody scrubs in and out of a case, you are doubling your contamination risk. So here's how it usually goes. Oh, Dr. Sweet, he's a jerk. He's going to yell at me. I better get the room all set up. So you go in early and you set it all up. Dr. Sweet's late again. That's time for a break. You scrub out, go get a cup of coffee while you're waiting for Dr. Sweet to come in, right? Then you scrub back in. You just double the contamination risk. Now you have, if you're training somebody, you have 2 people scrub in, 2 people scrub out for the break. That you've just fourfold contamination risk. You getting the idea? Oh, it's time for Susie to have a break. Well, the procedure's only an hour long, but she really needs a break. Now we have 2 people scrubbing, and if you got a scrub and a tech that, or a student scrub in and scrub out, now you've gone from 4 to 8 times the contamination. So one of the things you might think of is how people are taking breaks, how often they're scrubbing in and out. Does that make sense? Also, just how your gown and glove makes a big difference. So here's the staff. The number of staff in the OR, there's actually studies that show the number of staff in the OR are directly related to contamination risk. And we love to train, so we have students, but there's always nurses coming in and out. Why do people need to come in to talk to us in the OR? They really don't. There's a lot of times we just walk in, oh, blah, 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 and walk out. Somebody else walks in, blah, blah. You hear about Susie? Oh my gosh, you see what Trump did? Oh, wow. So all that in and out is not really conducive to a sterile environment. The experience of the staff is directly related to your contamination risk. If you've been a scrub for a really, really long time, you get bad habits and aren't aware of them, and people don't pick them up. They trust you. And if you're really, really new, you just flounder all over the place. So that's the people in between are probably a little bit better. So we all need to maybe challenge ourselves about how we're going in and out of the OR and our technique. What about our scrub? Chlorhexidine is really shown to be good. That's like Avogard or the chlorhexidine scrubs. It leaves a residual on your hands that lasts for hours. It reduces bacterial load on your hands for hours after you scrub. So one of the things I do is no matter what you scrub with betadine or chlorhexidine, after I rinse off with the Pseudomonas water, I put the Avogard on there. It looks like male hormone, we call it. It's disgusting, but it leaves the chlorhexidine coating on your hand. Can that be edited and taken out? So the other thing is, look how often people, you guys have beautiful hair, but it's very hard to tuck it up without someone sticking out. I'd say about 5 times a year, when I'm operating underneath the microscope, there's a thing that looks like a rope. And I pull it out, and it's a very long hair. I'm pretty sure it didn't come from this head. So it happens more frequently than we know. Little flakes off our skin, hair off our hat. So look around the room and see who has hair sticking out of their hair nuts even right now. Everybody, almost everybody has hair sticking out. So you got to be much more careful about how our hair sticks out and whether it's going to get in the wounds. Total joint guys use this. You know why? It's for one reason. It's to keep hair and skin things falling out in the wound. And it works. It reduces their infection rate. It also contains noxious gas if they've been eating beans the night before. Right? All right, so here's the skin prep. I love this picture. See that down there? I mean, it works if it sticks. So what happens is when you look at Iban, the reason it works is if you get it to stick and it covers the pores where the bacteria come out, you make the incision through the Iban, you don't get the bacteria coming up, right? So there's actually studies that look at skin prep. Years ago, Some total joint guys do this. So all they do is they take alcohol, they don't scrub it, they don't put betadine on there, they don't put chlorhexidine. They take alcohol and paint the knee or the hip with alcohol, put Iban on it. That's their prep. And it works. Their infection rate is just as low as everybody else. Because alcohol defats the skin, it makes the Iban stick really well. Crazy, isn't it? So then there are studies that look at chlorhexidine versus iodine, and we say, oh, chlorhexidine works better than iodine because it leaves a residual that kills the bacteria. Well, so we say maybe we should just use chlorhexidine instead of a iodine prep, right? So you know those chlorhexidine sticks that we use? Has anyone ever seen Iban stick to that stuff? It doesn't stick, it peels right up. So now you've totally wasted the effort of the Iban. Interesting. So if you switch just to chlorhexidine, you're reducing the effectiveness of the Iban. So DuraPrep is actually alcohol and iodine put together, and it's made for one reason. It really sticks to the skin, and Iban really sticks well to that. So that's a good prep. One of the strategies I use, people have seen, is I take that Avogard, or you can use a chlorhexidine, prep the wound with that, leave it on there a couple of minutes to kill the bacteria, wipe it off really well because the Avogard has emollients in it to make our hands soft, keeps Iban from sticking. So you wipe it off really well, it leaves a chlorhexidine residual. Then I use DuraPreps that has alcohol and iodine. So now I got chlorhexidine, alcohol, iodine, and I put an Iban drape down. So that might be another strategy, especially if you're working with surgeons that, you know, the Iban's coming off and it's not sticking. You got to think about the skin prep. What do you got to do to make that Iban really, really stick? All right. Antibiotic prophylaxis. Are we using the right antibiotics? One of the most common drugs that we use for prophylaxis is what? You guys know? Ansuf, right? You hear that? Is Ansuf in? Well, interestingly, if you look at the antibiotic sensitivity profiles, almost 60% of the staff, actually if you look here, right here in this hospital, 60% of the staff that cause over 90% of the infections are resistant to Ansuf. So for 60% of our patients, we're not giving any antibiotic prophylaxis at all. It's not working. All it's doing is making more resistant bugs, isn't it? But that's the recommendations of the infectious disease societies. So IV vancomycin also doesn't work. There's studies that show it doesn't work any better than Ansuf. It's a big giant molecule that doesn't penetrate the tissues, so it never shows up in the wound. You can see drug levels is floating around in the blood. It doesn't penetrate into the wound. If it doesn't get to the wound, it can't prevent infections. All right, so one of the things I do is if you use Ansuf and gentamicin, it increases your coverage to about 80 to 85%. I personally don't think that Ansuf by itself is a good prophylactic agent for orthopedic procedures. It's not, but that's what we still do. All right. There's another thing that was started several years ago. If you take antibiotics and just dump it right in the wound, like you see us dump who's seen the vancomycin powder dumped in the wound, right? What that does, instead of putting it through the vein, you just take it and put it right where you want it in the wound. If 95% of infections occur from contamination at the time of surgery, put the antibiotic where it's needed. And that's actually been shown to reduce infection rates up to 10-fold. It's pretty powerful. Now, it's not going to work in like gynae surgeries or colon surgeries where the big bug is like E. coli or some of those, but guess what also works? Gentamicin or tobramycin powder works, but those you have to be careful. Vancomycin you can dump in as much as you want and it's not absorbed, so it's not systemically detected. It doesn't hurt the kidneys or anything else. That's actually a study we did at the Rockford Spine Center. We know that. However, if you take gentamicin or tobramycin and put in too much, it's absorbed very rapidly, and it's just like giving it IV. So if your surgeon's going to use tobramycin powder directly in the wound, it should be weight-based. 3 to 5 milligrams per kilogram. So if you have a 100-kilogram person, they probably shouldn't be putting more than 300 to 500 milligrams or maybe half a bottle of the tobramycin in. vancomycin powder, they just put as much as they want in. $6 a bottle. It reduces infection rates so significantly, the average hospital saves $1.5 to $2 million a year in infections alone. Each hospital. All right, dilute betadine lavage. That was used, you can see, who's seen surgeons do that? Years ago, general surgery, we tried doing that. It did not really work. In fact, it increased our infection risk. But people are always looking for a way to reduce infections. And so they, at Rush, one of the total joint guys, they did one study now. They showed a slight reduction in infections with total joints. One study. So everyone gets excited, let's do it again. We've kind of forgot about all the studies from 30 and 40 years ago that showed it's actually a negative for wound healing and wound infection. There's also a rat study. Actually, that's one of the things I was typing early this morning. I did surgery on 120 rats, if you can believe it. Did spine surgery on 120 rats. And if you think finding a vein in some of our patients is hard, try finding a vein to give antibiotics in rats. Anyway, this rat study shows the betadine in the wound doesn't really add much. All right, post-op care. There's that new Aquacell dressing, right? It sounds sexy, sounds great, everyone thinks it's cool, just like the new total joint, the total disc replacements, and we do it, and then all of a sudden there's lawsuits. Does anyone remember the movie The Jerk?
Yep.
That little thing on his nose, on his glasses, made bazillions of dollars till everyone was cross-eyed, right? So we get new things and we try them, we think they're really cool and great. But that Aquacell, I'd be very careful of that. It's an occlusive dressing that prevents oxygen from getting into the wounds. No oxygen, your own immune system can't work without oxygen. The white blood cells don't work without oxygen. Bacteria love no oxygen, and it holds in moisture. And all those bacteria that are in the little pores and sweat glands, when you have something covered tightly, it sweats under there, and I think it creates a great environment for infection. So, and they also peel off, so you can't really take a shower after a couple days anyway. A lot of people are using those. I would be careful of that kind of dressing or any kind of occlusive dressing. That's one of the reasons you see that Metapore tape we use. It's very porous. It lets it breathe, lets air get to it. Air is good. You guys know how they used to treat wounds in the Civil War? They leave them open. Just pack them open. Didn't have antibiotics. They were able to treat a lot of wounds that way. So air is good. Skin closure. If somebody is really heavy or diabetes, we tend to use staples and or these superficial wound vacs. That negative pressure therapy works really well. It draws the extra fluids out, and it promotes blood inflow that carries oxygen and the little white blood cells in the wounds. So these wound vacs, you guys have seen those? Yeah, we should use those more, especially with our big stout Americans and if they have diabetes or rheumatoid arthritis, immune suppressive stuff. So the wound closure and the wound vacs all help. Oh, this is just a picture of the rat study. See what we did. So we just took rats, we shaved them, betadine paint. We actually put the Ivan drape on there, and we took a bunch of rats. We gave a bunch IV antibiotics, and we gave a bunch no IV antibiotics. The ones that didn't get the IV antibiotics, we put in like vancomycin, tobramycin, Ansef powder, or use the betadine lavage. Okay, and we compared all those to see what works. And then what we did is when we put these vascular grafts that are very porous, we stuffed them in there and we dumped 1 million staph bacteria in there. Do you know how long it takes to count 1 million bacteria in each one of those rats? So what we did is after 7 days, we let them eat, drink, be merry, ride their bicycles, fly airplanes. And after 7 days, they suddenly died. And then we would go in and reprep them, take out the grafts, and we would culture them and see what happened. So here's what the grafts looked like when we took them out. They look really pretty clean, and the infected ones look terrible. You can see all the bacteria growing on the cultures. And here's the results. So IV vancomycin and IV cefazolin had a 100% infection rate. This is a pretty tough model, very high contamination, right? Vancomycin and tobramycin only had a 20% infection rate. Ancef powder, these are powders just put in the wound, and they did not get any IV antibiotics, just local antibiotics in the wound. But look how well these two did. Ancef powder directly in the wound was better than Ancef IV, and then betadine lavage didn't really do much of anything. Now, betadine might do something in humans. How often do we take 1 million bacteria and throw it right in Dr. Antonacci's total joint wound? He wouldn't be very happy, right? So, but that's just interesting data I thought we'd throw in there. Okay? Now, that was as fast as I could give that whole talk. What do you think? What questions do you have? Yes?
We still have people that use the Bassi poly in saline. How do you feel?
Yeah, that actually does help, but it's not the antibiotic. There's actually some really good studies that looked at. It's the foaming agent, basically the soap that suspends the antibiotic that's in there that does a cleansing action. So there's some very interesting scientific study that looks at it's the soap in the Bassi poly that works. So if they want to give it to them, especially in trauma, it helps to debride out the dirt and that kind of stuff. So, yeah.
Some people mix the gentamicin and cement. Does that slowly release into the body?
Yeah, so that's very interesting. There's a whole journal on, it's called the Journal of Biochemical Elution. And it's, it's a whole journal devoted just to things like antibiotics coming out of bone cement and cement pellets and calcium phosphate. As it turns out, the gentamicin, when it elutes out of the bone cement, produces a concentration in the joint about the same as if you give it through the IV. So it's hard to know that it really produces a significant advantage, but it's one of those things that's been done for so many years that everybody does it when they're trying to treat a joint infection because it's a nasty problem that's hard to get rid of. You know, it's like using kite string, duct tape, Elmer's glue, and a little this trying to get the broken model to work, right? The antibiotics in the bone cement may help some, but they're not hugely advantageous. And those are also to treat established infections, right? They don't generally put antibiotics in bone cement in a primary total joint because there's studies that show it weakens the cement and the cement's more likely to fracture, then they have to revise the total joint from that. So they tend to put the antibiotic cement in when they're doing a revision for an infection kind of thing. Now, if you take the antibiotic and pour it directly into the wound, the study we did was published about 8 or 10 years ago, the vancomycin levels in the wounds were, instead of being 10 or 15 like you get from the blood, we're up to 2,000 and 3,000. So I mean, it's really huge doses in the wound that probably sterilize the wound. Yeah, any other questions? Are you sure? Were you sleeping? Did we keep you awake? All right. If we had more time, I'd like to call on more people and embarrass them, but you guys were spared that. All right, well, thank you very much. I appreciate it.
Thank you.